let's go. Here we go. Children, we're going now. Okay, I did what I could do to round them up. Okay, let's see what we got.
The truth was, have you been a cowboy in California?
Say again?
Have you been working as a cowboy?
As a cowboy?
Yeah.
No, that's cowboys are
No,
from the old
because
West.
cowboy you can collect the cows, then you can collect the people.
Oh, okay. Well, you're right about that. Okay, well, we do what we can do, you know. What can you say? So I was asked to give 2 lectures in this slot for a 45-minute period, but now it's a 20-minute period, so each one will be 10 minutes. No problem. We adapt, okay? So should we start now, Professor?
Please start.
Okay. So this is a lecture I originally gave when we were in the program in Cairo at the Pan-Arab League headquarters. And I've been interested in this, though, for some time. And I'm pleased to give an updated, of course, lecture, because everything is updated to the present. So back to the future. We had therapies before with those expensive steroids, calcineurin inhibitors. You've heard how Professor Al-Kabati talks about the cost. Cost is important. Our patients can't afford these medicines often. And tar is a proven choice. So I wrote this article in Back to the Future, tar. Next. Here we are again. I'm sad to say I have no conflicts of interest. There's my wife and son and dog in Italy, L'Aquila, going around, we were driving around Italy last summer. Next. Okay. So this, again, was used for years and years, for thousands of years, by Hippocrates, recommended pine tar in medicine. Coal tar has been used for over 2,000 years. And Cappucci, in his book, recommended it too. So this is our article in the Journal of the American Academy of Rheumatology in 2009, tar Back to the Future. Next. Okay, here we are again with the Greek monument. Next. Okay, next. And of course, some of the mysteries are buried in those monuments. So, the whole point is tar was not just for live people, but for dead people. I showed you a picture of a dead person, or a casket. And the Egyptians used tar for embalming. They like juniper versus cedar tree origin tars. And of course, recent work favors the cedar origin. Herodotus talked about this in his history. The famous Greek historian, remember, Orphanos said he reads Herodotus in the original Greek. I wonder about that, but it's hard to read original Greek. But in any case, this is a therapy that works, okay? It doesn't cost a lot, and that's very important, like carbon dioxide slush. Next. Okay, so here we treat everybody. We treat Grandpa. We treat our dog. You like that? Okay, so next. These are products on the market that are very good. Okay, we have tar ointments, tar gels, tar creams. I think you have, again, the trade names aren't important so much. You have these tars too, don't you? You guys use these tars in the Republic of Yemen? They're using it too, using the tar commonly? Again, it's very cost effective. Certainly more better than the biologics, which are outrageously expensive. Do you use tar in your treatment? Okay. Next, please. Okay, so again, here's some of our favorite tars. Medicated shampoo, whether you put it on the skin, a number of approaches for tar. Next. Okay. So there are, three main types of tar. Coal tar, wood tar, such as pine, birch, beech, and juniper, and the shale tar. Really from fossil origin. Next. Okay, and this is our textbook chapter published last year, Tar in Dermatology, review of the therapeutic evidence in evidence-based dermatology. So, leftover byproduct of coal processing and distillation. Tar is a leftover product. That's one reason it's not so expensive. confusing is that there are thousands of chemicals in crude coal tar, only a fraction of which have been identified. So we don't really know what we're putting on, but we know it works. Next. Often it's given in terms of liquor carbonous detergent and can be made by mixing, as you can see here, topical tar solution with polysorbate and alcohol, or compounded, I like with salicylic acid and with triamcinolone, with a medium potency steroid. Okay, the combination, very effective. Okay, and the tar is cost effective too. We find that if you let the pharmacist compound it, it costs a fortune, but the patient can get these separately and apply them and mix them on the skin themselves. Okay, and also that's an advantage because sometimes tar is a little messy. Next, okay, so coal tar extracts resemble LCD, made from different solvents, dissolved in gel, liquid, shampoos, and again, there are a lot of, we want to make it as cosmetically appealing as possible, because again, tar is messy, they're smelly, there's some downsides. Next, but they work. Okay, phototherapy with tar, and this is, again, so much works with adding tar and light. And phototherapy, the old Geckerman, tar with the Geckerman regimen, with tar with ultraviolet light, can be applied usually 2 hours before the ultraviolet light. You're blessed with a lot of light here. So you can give them the tar, they can go out in the sun, and that certainly is cost effective. Next, coal tar phototherapy, tar and UVB alone are active. Together, they're better. Crude coal tar can sensitize, but tends to sensitize more with UVA than with UVB. Yet UVB is better with tar. Next, derived from the wood tars. Remember, there are 3 types of tars. The wood tars come from destructive distillation, and they have less photosensitizing effects, increased risk of irritant and allergic reactions, however, and cross-reaction can occur. Next, how are we doing on time? Okay, shale tar, destructive distillation. Next. Okay, and wood tars, blend of tars. I like polytar. You guys have polytar? It smells nice. My patients like it. Although remember that if they accidentally ingest it, they can have fever, hypotension, renal failure. They shouldn't be drinking it. Next. No surprise. In fact, tar toxicity with nausea, vomiting can be a problem, especially if you have like a little baby. Somehow you treat a little baby, what you shouldn't do with erythroderma, because babies, absorb a lot of stuff through their skin. They absorb it. So a generalized absorption in erythroderma, even with an adult, can be a bit of a risk, but with a baby, certainly. Next. Okay, carcinogenicity with tar is admittedly always a concern. Really more in animals than people. We found that really with people it's not such a problem. There's no real evidence that over-the-counter tar products are carcinogenic, and there's no really increased risk. This is a huge study, 13,000 patients. So it's not such a problem. Next, patient precautions. Tar makes one more sensitive to sun exposure. Avoid prolonged exposure. And certainly you want to gradually get the exposure. And certainly in pregnancy, we don't know if it passes in the milk. Anytime a woman's pregnant, I say, stop everything. You don't know. Next, a World Health Organization classifies tar as carcinogen over 5%. The great Republic of California, my home country, we were free for all the 10 days. Classifies it again. Typically, California does everything different. We say over 0.5% or more makes someone label it as a carcinogen, and the FDA considers 0.5 to 5% as safe for psoriasis. Next. Okay, that's a bunch of rings didn't come through. Next. Topical uses, as you know, atopic, seborrheic dermatitis, neurodermatitis, and in much of the world it's the first-line therapy. Do you guys use a lot of tar? Are you?
Yeah.
I urge you. It's really cost-effective. That's important. And often keeps it away, too. You not only want to get rid of the eruption, you want to make it stay away. Next. Okay. This is a quote I typed in from Moritz Capocci's book. tar is usually applied in the following manner. Okay, they did that in 1895, and they really scrubbed it in. This is really amazing, because again, we don't do it quite that way, but they hospitalize a lot of patients, and it's done a little differently the way he did it, scrubbing it into the patient energetically. Okay, we don't tend to do that. Next. Okay, so special considerations, the Geckerman approach, using the tar, broadband UVB in the mornings after the tar overnight, low cost, high efficacy, disadvantage, the odor, the messy smell, staining clothes, and possible carcinogenicity. Next. Okay, current renaissance for this treatment, I think it makes sense, and I favor it. High cure rate, even compared to biologics, which cost a fortune. Next. Okay, so here's, courtesy of my friend in the Czech Republic, you can see here, tar versus fancy, expensive biologics, and you can see that basically the results are the same. Better. And it doesn't cost thousands and thousands of dollars. Okay? So I urge you to think about the standard tar light therapy for your psoriasis and other patients rather than going directly to biologics, which are so expensive. I mean, we don't know the long-term effects with them. Next. Okay, so Geckerman versus biologics, the cost, 3 weeks, 50 euros, 3 weeks, 4,620 euros. One is parental, which isn't so pleasant. The other is just on the skin, which is annoying, I grant you. You can see the duration here. And again, some of the positives and negatives that we've already covered. Okay, next. Mechanism of action, suppressing DNA synthesis, vasoconstriction. TARs are actually antifungal, antibacterial, antiparasitic, and antipyretic. So they're good for a lot of our dermatitises, beyond psoriasis. Next. Okay. Mechanism of tar action, again, it can be a photosensitizer, which would be positive or negative, anti-inflammatory, inhibits sebum secretion. Next. Okay, and we're worried about the carcinogenicity. Next. This is, again, the typical product on an American market. Does not discolor naturally, light or colored processed hair. Okay, next. And you can see we have some fancier ones too, that are more expensive, that are more elegant. This is a patented special preparation. Next. Possible tar side effects include folliculitis and acneiform eruptions. They're the main ones I'm worried about in my patients. Stinging sometimes initially, burning. You could actually get a drug eruption from them as well. Next. Okay, atrophy, atopic dermatitis. Again, everything ultimately can produce problems, including keratoacanthoma. Next. Okay, so here we are in the Great Wall of China with Karl Halabar, who recently passed away. And the last slide, and we're going to go to the next lecture, last slide, in Isfahan. How many of you have been to Isfahan? Besides Professor Yassim and me. How many of you have been to Isfahan? No?
Some people.
If you've seen Isfahan, you've seen half the world.
No, they are absent, but some people they have been there.
You've got to see Isfahan. It's not far from here, okay? Okay, go with dysmorphophobia. Okay? 10 minutes, and now the other lecture for 10 minutes. And okay, here we go. So dysmorphophobia, or body dysmorphic syndrome, is all too common. And we see patients more and more coming disturbed, distressed. You got to be very careful who you operate on. You operate on these people, you'll regret it. Next. Okay, so here we are in the Arab League headquarters. I want to dedicate this lecture to Karl Halabar, who passed away recently. You recognize our friend Mohammed Amer and distinguished Professor Yassim. Okay, and this is Arab League headquarters, 2010, for the meeting. Next. Again, sad to say, I have no conflicts of interest. I'm a no drug company payrolls. Maybe someone wants to put me on their payroll. Okay. Okay, so here's a young lady. Her face is, she comes to you, her face is a complete mess. She says her nose is swollen. She's deformed. She's a complete disaster. She wants you to operate on her next. But you look at her and she doesn't look so bad, does she? Huh? What do you think? Doesn't look too bad. Okay. Dysmorphophobia, body dysmorphic disorder. People think they have nothing on their face and it's destroying their life. You operate on that, you'll impose the problem, huh? Body dysmorphic disorder. Next. Okay, common, yet often unrecognized, affects initially adolescents, both sexes equally. And again, can be disabling or life-threatening. These people may kill themselves. This is my chapter with our colleagues from Johns Hopkins in psychiatry and the online e-medicine book. How many of you read e-medicine online? It's free. Good, good. I recommend it. Okay. So a non-existent or slight flaw of the face is often the primary complaint. A slight blemish, a freckle, a mole, minor acne. And these people their lives are destroyed. Too much hair, too little hair, hair in the wrong places. The shape or size of the nose, face, breast, other anatomic sites. Next. You always have to think of this. I had this 35-year-old guy who had a little median nail dystrophy. No pain. He comes in, his life is destroyed. He's worried his underlying cancer. That's a common concern in these people too. Do I have cancer? So the guy obviously wasn't in the real world. I sent him to the orthopedist. They refused to operate, as it often happens. So he goes to some surgeon. Surgeons, with all due respect, will operate on anybody. Okay? So they operate. They tell him there's a glomus tumor under there. They say, well, some glomus tumor is going to be malignant. So he has all these things operated on, all the fingers, and of course they're not cancers. They're not glomus sarcomas. So they have these people that have cancer phobia. This guy had cancer phobia, extensive surgery for the unlikely chance of being malignant glomus tumor. Then he's been harassing me. He's been demanding money. This is what you get with these people. Don't operate on them. Even if you don't, sometimes you're going to lose, as I did with this guy, although he got lost, thankfully. But these people are losers. You've got to separate them out. You can't operate on them. You can't inject them, or you will be the cause of their problem. And they'll be harassing you, or in America, suing you. I'm very lucky. I got them right away. We documented everything we did. So they but if we'd been a little sloppy, we'd been in real trouble. Next, in terms of documentation. Okay? We have to protect ourselves from unrealistic expectation. These people can respond poorly to anything you do. They're never satisfied. The major challenge is detecting them, making sure you don't operate on them. You have to select your patients very carefully. Next, anything cosmetic. 1/3 or more of patients have compulsive skin picking for hours a day, at times with tweezers, needles, pins, even razor blades. They're convinced that the defect is immediately obvious to everybody. Because they look in the mirror, and there's just, no one sees it across the room. And again, next. Okay, so they have imagined major defects, face, nose, and they go doctor shopping. So they come to me, I tell them I'm sorry, they go to you, they go to next, whoever's foolish enough to operate on them is going to regret it. Okay? Here's our paper in the Acta Dermatologica Gratica, and another paper in the International Journal of Dermatology. Okay, we have another one hopefully coming out soon. Next, on this topic. So, a study, I lectured on this in China in 2010, so I include a Chinese study, but again, is around the world, and just among medical students. 1/3 of them are very concerned about some aspect of their appearance unrelated to weight, and a certain percentage, this is self-reporting, so the data is very low. Next. But it's real. These people often have this is really an obsessive-compulsive disorder that interferes with daily activities, living. Next. Okay. These people are angry often. They have increased levels of hostility. Some have been violent. Actually, have killed their doctor, literally. Anger and violence can be directed against the surgeon, particularly if they're foolish enough to operate on them. An actual murder of dermatologists has happened. Next. Okay. So this, a moral weakness does not cause body dysmorphic disorder. Vanity does not cause it. These people aren't just vain. Stress does not, but stress can exacerbate it. A young lady or a young man in school, stressed by the examinations, this will make the problem worse, but it doesn't cause it. Puberty doesn't cause it, but it exacerbates it. All those wonderful hormones. There's no single cause, but a combination of neurobiologic and genetic factors are probably related. Next. Okay, a twin study from the UK that I rather like, over-concern with the perceived or slight defect in physical appearance appears to be an inherited trait. Okay? Next. And this goes along with trichotillomania, nail biting, ritualistic picking. Next. And we have a paper on that too. Again, this is classified by the psychiatrists in their system. Obsessive compulsive disease, the MS4. Next is the latest. Dysmorphic delusions, indistinguishable. Next. Okay, this is the classic book. I urge you to read if you have a patient. The Broken Mirror, Understanding and Treating Body Dysmorphic Disorder by this psychiatrist up at Brown. Classic for both patients and physicians to understand this. Next. There's your book, The Broken Mirror. Very, very good. Next. Very insightful. An obsessive and irrational preoccupation with the slight or imaginary defect. Again, obsessive compulsive disease. Next. Next. It affects probably about up to 5% of college students would meet this criteria. 1 to 2% of Americans overall. Next. Okay. And in Brazil, they broke down cosmetic versus non-cosmetic. And people coming for cosmetic problems is even more common, 15%. Okay. This is from Sao Paulo. Next. Okay. Poor body image, poor self-esteem. These are related. Next. Okay, occupational and functional disability. These people have trouble working. They don't work in school. They don't work on the outside. They really are disabled. Next. Okay. And they may kill themselves or kill the doctor. Suicidal ideation, over half. Next. Okay. And they have disturbance in serotonin activity. They don't admit their concerns. Very poor insight, typically. And again, some are delusional. Next. Okay, MRI and other studies have shown changes that are really noteworthy, but beyond level of dermatologic interest. Next. Okay, delusions present. Often mandatory to exclude actually other mental disorders too, because these people who are schizophrenic, okay, can be well beyond the normal. Next. Okay, so this major depression may coexist, social phobia, they may have panic disorders, and again, they may be frankly schizophrenic. So, have you all seen patients? Have you seen patients with this?
Yes.
Okay,
Yes.
you've all seen patients with this, and you really have to be careful. It's easy to get into a trap. Next. Okay, so you want to screen very carefully. There's some tools you can use with these standardized questionnaires. I don't use them. Next. Use your clinical judgment. More important. Now my friend Alan Shalita likes some of these tests. Next. Okay. People that tan, the tanning bed people, they are higher incidence of this. Next. Okay. These people have social lives that are filled up, jobs that are filled up, academic careers that are filled up. Sometimes they see their dentist too. Anything to do is difficult. Next. Okay. Almost half of them have eating disorders, may have anorexia nervosa, and these have to be treated, identified, because they're treated differently. Next. Okay. They're often perfectionist, unrealistic expectations of themselves and others, lack sense of identity, and become angry or even violent at times, particularly with their physicians. Next. Okay. Again, we talked about how common it is. Next. Skin picking, again, it's showing again how it's related. Next. Untreated tends to be chronic, potentially disabling. And again, we want to avoid the cycle of multiple surgeries to improve imagined flaws. Outcome is poor. It leads to exacerbation of the symptoms, anger, and in America, lawsuits. You guys don't have to worry about that. For us, anybody can sue us for anything. Next. Complete nightmare. SSRIs are the treatment. They have trouble too. Antipsychotics are usually not effective. Behavioral group therapy is the best, but they often won't admit it. Again, patients have poor insight. So getting them into therapy is a nightmare too. Next. Okay. Natural remedies do not work. Trying to uncover some psychiatric trauma is useless. Reassuring a person that he looks fine is not helpful. Just makes them angry. Most get better with the SSRI and or the cognitive behavioral therapy, with the last being the best. Next. You want to recognize the symptoms, speak seriously, encourage psychiatric therapy. If you'd like to focus, you're suffering so much, why suffer? See the psychiatrist. I know you don't want to do that, but you want to help yourself. Don't try to talk a person out of their beliefs. They'll get nowhere. You're just meeting obstruction. Don't give reassurance. Don't tell them, oh, you're really not so bad, the mark isn't so bad. That doesn't help. Give praise for any small gain where they're functioning better. Next. Okay. Don't participate in a ritual reassurance sinking, which they all want to, I don't look so bad, do I? Look at me again. Oh, it's nothing. That doesn't help any. Ritual reassurance seeking is a symptom of the disease. Doing so feeds the disease. Saying someone looks bad worsens symptoms too. You need to say, I know you're anxious, but reassuring you won't help. Next. Okay, you want to limit involvement with the rituals. Decline to participate in the rituals, such as measuring a body part when they come to your office. Do not feed the disease. Try to convey understanding, not anger. Don't get frustrated with them. Don't provide excessive care for these sufferers. You're not helping them. Overprotection implies that the person can't do it for themselves. Again, just understanding. Next. Okay. And by the way, SSRIs, we have a paper on that. And SSRIs, the complicated things can produce a whole bunch of skin problems too. Okay? These medicines have problems. But that's kind of all we have, as well as the psychotherapy. And there's our paper in the Journal of American Academy of Rheumatology on the side effects of SSRIs. Next. Okay. So sometimes there's magic involved, sometimes there isn't. There's Karolotti, our friend in Roma, and Jana Hertzakova, who's the president of the European Academy of Dermatology, and my son and the magician, because you need some magic dealing with these people. Next. And there's my wife in Kuwait. She loves to come to Kuwait and talking to a girlfriend of hers, as you can see. So thank you all for listening to me.
Competition. Program is not going in the correct way because some people are absent, some people are reluctant. So I suggest Dr. Alhamdulillah. Then after I have Dr. Manchester.